So the question is, where do we see primary care coming up short with respect to the differential diagnosis of back pain? And the issue really stems from something greater than that. Primary care has something much more important, much more valuable to offer than anybody, and that is they are the primary portal of entry for that patient to be seen. And unfortunately, it's gotten to the point that because people are so limited in time and resources, that when they see a patient, let's say, who has pain, they automatically think of referring the patient to a specialist, and we'll hold that out in quotes, to evaluate that patient, thinking it's going to be offset because they don't have the time to be able to see that patient because there's only so much time in the day, and everybody seems overworked and overscheduled. The problem is that the physician can take a step backwards for a moment and take a little bit of more time to evaluate that patient and better triage that patient. Then we can determine maybe what better that particular patient needs at that particular point in time in a highly patient-centered manner. Because there's all sorts of things that we can do for a patient. So let's take the diagnosis of back pain. I can probably sit here and name 40 different causes of back pain. And then oftentimes the patient will even have more than one cause contributing to their back pain. So if we take back pain as a diagnosis rather than a symptom, which it is, we would essentially just be throwing darts at a patient, hoping something might work. But on the other hand, if somebody was to be able to take a step backwards, put a little bit more time into examining that patient so we can get a highly more patient-centered diagnosis, such as this patient might have a mild facet irritation at L5-S1 causing their back pain, which is now causing the L5 nerve root to become inflamed. So now we have a specific diagnosis, much like you would a knee. Or what about the things that cause back pain that are not even in the back? It's so amazing to see how many people we see that present having been treated for back problems because somebody looked at, let's say, a disc herniation that might have been on an MRI, and yet no one ever did an examination to find out that the patient actually has a sacroiliac inflammation, a sacroiliitis, when we could have treated that with a sacroiliac injection directly, not putting the patient back through surgery and therapy and a variety of injections focused to a disc herniation that might have been a red herring. In 2013, there was a study that came out of China where they evaluated 3,107 patients that were seen in 2 different ERs during the month of January 2013 for the purposes of acute low back pain. And in doing that, 58% of them had completely normal MRIs, 42% had abnormal pathologies on their MRI, but there was very little correlation with the level of the pathology on clinical examination with what they saw in imaging studies. So what does that tell you? You have a 50-50 shot of having a pathology on MRI, whether you have pain or not. And we can take a scenario. Let's say we did an MRI, and then you say, okay, the patient has this disc herniation at an MRI, on an MRI. What do we do? Oh, maybe we can do an epidural. So if you do the epidural injection and the patient gets better, if you repeated the MRI, wouldn't the disc herniation still be there? You know, and the answer, of course, is yes. So you use the MRI for some diagnostic specificity, but it turns out you really didn't call the pathology quite right because the pathology is still there and you just created a situation where you have an asymptomatic patient, yet you have a pathology on imaging studies. In one of the neck and upper extremity sessions, we talked about another study where they evaluated, I believe it was 500 patients that had no neck pain and looking at cervical MRIs, so they were completely asymptomatic. And they also found a very high distribution of pathologies on those patients. The scary number was that almost 10%, was about 8% of the patients from 60 years or older were identified as having severe spinal stenosis, which would be highly indicative of a surgical decompression, according to the imaging study, but yet the patient doesn't have a single complaint. Are we going to operate on that patient? So these are red herring diagnoses that often lead to a lot of wasted healthcare dollars. And if you operate on a pathology that's not symptomatic, one, you're putting the patient at risk, and two, many times you're actually then doing a surgery that causes more harm, and that actually violates the first rule we have in healthcare, which is what? do no harm. One of the interesting things we consider is failed treatments, because there are very treatments that are highly specific. You know, if you do an intra-articular facet block and you do not get a response, I mean, that basically says maybe the problem's not located to that facet joint. I mean, the patient tells you a story. They tell you how it happened, what is going on, what makes it better, what makes it worse. With this information in hand, you as the physician then perform a problem-focused examination to help rule out or rule in whatever you think is causing the problem so that you can get a better diagnosis. Listen to your patient. The patient's going to give you a lot of information. Examine the patient, tease it apart, get that working, highly patient-centered approach, and you'd be surprised what you get for an outcome. If you can eliminate one unnecessary back surgery, how many extended patient consultations would that pay for so you can spend more time with the patient on the front side, which might eliminate the need for yet another low back surgery? So there's ways of doing this. You know, if you can eliminate the need for an unnecessary injection or an unnecessary MRI and put the money into what is the most valuable service, which is that hands-on clinical examination, listening to the patient, where would healthcare be?